Okay, Chapter 12, Part 3 of Medication Administration. This is the third and final part of this chapter's lecture. In addition to this, remember there's a couple of additional PowerPoints, though, that you'll find that cover adult interosseous access and a little bit more on calculating medication doses. So in Chapter 12 here, Part 3, we're really looking at starting IVs or IV access and intraosseous access, mostly in the pediatric patient, although the adult patient really doesn't vary much from what we're going to learn in this chapter or this part for the pediatrics. So when we're looking at an IV catheter, this is one of the most common style of cathetons here. It's not technically a needle. It has a needle within it, but only to get it into the vein. So from looking at this picture here, we have the flashback chamber and the hub, the catheter, and what you see is called the stylet. They don't do a very good job of differentiating there, but that stylet is the needle that is within a plastic or Teflon tube, which is the catheter. This style of catheter, and this is called catheter over the needle, meaning that the needle is in the center of the catheter and is pulled out. There is a rarely used type of catheter that's actually a needle over the catheter or catheter through the needle device, in which after the catheter is introduced to the vein, the needle is withdrawn. However, it stays within a shield or a guard. In this type of catheter, everything that's the bluish colored flashback chamber and then the needle within it will go away, and only the pink hub and white cathlon or catheter will stay in the vessel. So with this style of catheter and that flashback chamber, once the needle is introduced into the vein, blood will come up the center of the needle, and you will see it in the hub and you will see it in the flashback chamber. And that's how you know that you have hit a vein. There's a little bit more to it than that, but the white kind of D-shaped thing right above the words flashback chamber there is actually a spring-loaded button. When you hit that button, it will withdraw the needle, and it springs it back into the rest of that chamber there. So establishing a peripheral IV line is going to give us access to administer either fluid or give medications. We also sometimes will use it to obtain a blood sample, but you don't always need to start an IV. IVs are not absolutely the end-all be-all of ALS treatment. Most of the medications we give at the AEMT level don't require an IV, and IV fluid alone is very limited in what it can do. But in most cases, when we start IVs in EMS, it's really precautionary. It's more of we're going to have an IV in place in case something bad happens. So usually we're obtaining this IV line by using a catheter surrounding a hollow needle, and of course we'll have protocols that will give us some ideas on which way do we select what sorts of fluids we're going to use and what sizes of cathlons that we're going to use. So when we're talking about fluids, we use in the AEMT setting, or if you remember back, if you were an EMTB and had taken IV maintenance, you can use a crystalloid solution, meaning, and when we say crystalloid, we're really referring to a solution of a crystal dissolved in water, and that in most cases is going to be either salt, making it normal saline, or a saline solution, or sugar, making it a dextrose-containing solution. Or there's a third type of solution called lactated ringers, which is kind of a mixture of those two, both maybe a little dextrose, very little dextrose, but mostly salts, and then some other salts like some of the other electrolytes like magnesium and whatnot. So we have a couple of solutions we can potentially pick from. Additionally, we got to gather the appropriate other supplies. We're going to have gloves on for our standard precautions. We're going to need a venous constricting band, what's often called the tourniquet, and that tourniquet is going to be used to constrict the blood vessels a little bit and allow a little blood to back up and cause the vein to kind of plump up for us. A cleansing substance, usually alcohol, maybe iodine, maybe chloroprep, and then whatever we're going to attach to our catheter, whether that's a lock, which is simply a cap, or it is a tubing that goes to our bag. So we need a bag and tubing, or the lock. So depending on what we decide to do, which direction we decide to go, will influence that. Additionally, we need our needles and the appropriate sizes of needles we'll get to talking about the catheter size here in a minute, but there is a variety that we pick from. Small gauze squares or a commercial IV dressing, adhesive tape, or another type of IV securing device. And in some places they also prefer to use a little antibiotic ointment or a tincture of benzoin to help reduce the possibility of infection. So on that topic of catheter size, catheters are in a gauge measurement system, and by gauge, the larger number of gauge, the smaller in diameter the needle. So when we're talking, the general range of catheters are even numbers between 14 and 24. So 14, 16, 18, 20, 22, and 24 are typical catheter sizes. 24 is about as small as it gets, and 24 is about as big as it gets. There are others. There are 26 gauges. There are 10 and 12 gauges. But they're usually the size extremes that they're really used for something else that is really a specialty, like a neonate or another, actually not an IV, but another instance in which you need a hollow catheter. Typically, we will start an 18 or a 20 gauge in most healthy adults. We will start a 14 or a 16 gauge when we need a lot of fluid, such as a major trauma patient, and a 22 to 24 gauge for those with smaller, fragile veins, such as pediatrics and some of our elderly population. We can have adults that have very bad veins as well, but we prefer to do 18 or 20 on medical patients, 16s or 14s on trauma patients or other patients that need fluid. So to set up our IV fluid and tubing, first of all, we're going to check the IV bag. We're going to make sure it's the correct fluid, make sure that it is not expired, the date is within range. We're going to inspect the bag and know that an IV bag comes in another inner wrapper, and it's hard to, you really can't see it from looking at page 311, but there's usually a thick kind of semi-cloudy wrapper, tough wrapper that goes around the outside of these IV bags to protect them. So we're going to look at that as well to see if there's any condensation or leakage of fluid in there. After we remove it from that tougher outer bag, we look real closely at the bag again, make sure it doesn't have any leaks or whatnot. We're going to look for clarity and make sure we don't have any particulates, which a lot of people call floaties. There shouldn't be any of that in there. Color, in most cases, the color should be about as close to clear as possible. Now, understanding that the plastics that the bag are composed of may alter it slightly, but in most cases it's about perfectly clear. And then do not allow the sterile portion of the tubing to come in contact with anything. And when we say that, if you look at 311 and picture number 3, they're actually spiking the bag, and that spiking of the bag has a sterile tubing, spike on that tubing that the drip chamber is just below, and that is being then put into a port on the bag. That port typically also has a cover over it to keep it nice and clean as well. So keeping a medical asepsis the best as possible. So we're going to also then talk about sites for peripheral venous access. And in most cases, we're going to deal with arm and hand veins. These are peripheral veins. Anything that's on the trunk itself is not a peripheral vein, so it's not typically something that you're going to be able to do. So there's a few veins up around the bend of your elbow, which is called the antecubital fossa. Most people have 3 veins that run through there. There's normally a cephalic vein that runs from along the thumb side or the radial side of your arm. It usually comes down your forearm. You have a basilic vein that runs down the back side or the ulnar side of your arm. And then when you look at the hands, there's usually a nice venous network on the back of the hand. At least 2 or 3 decent veins usually run across most people's hands. There are other places that we can potentially look. We can look for things in the foot, sometimes in the leg, and then a jugular vein. The jugular vein is the large vein that runs down the side of each side of your neck. That is considered a peripheral vein. So when we're selecting a suitable vein, we're going to look at the hand, we're going to look at the forearms, antecubital fossa, the anterior elbow. We can look at the lower extremities. You can look at the external jugular vein in the neck. They say no, but that is classified as a peripheral. Venous tourniquets will then be used to help restrict the venous flow and engorged veins. So not the jugular vein. We do not put a tourniquet around the patient's neck to slow that down. A little trick you can do though with that is if you have a stethoscope, take the stethoscope and put it around their neck. You put the stethoscope around their neck, it puts just a little light pressure then on their neck and will help those veins pop up just a little bit. Now, when you're selecting a vein, look everywhere first before you start going and poking, because sometimes patients have really crappy veins in one arm and really good veins in another. So look it all over and get a good feel for it before you say, okay, here we go, we're going to poke. Use prominent, more superficial veins that are readily available, they're visible, and then the deeper veins can be a little bit more hard to get. A suitable vein is spongy and springy feeling on palpation. So most of you can probably find a vein along the back of your hand. And if you look at the back of your hand and you find one of these veins, just start poking at it with your finger. You might have one that runs along the wrist. So if you would follow your thumb right straight down to where it runs into the radius, there's probably a nice vein right there on that surface of your wrist. And you can probably find a couple veins along your forearm, particularly in the antecubital fossa. When you find some veins, play with veins. Touch them, feel them, they should be springy. If you find one that feels like you're pushing on a piece of like rubber rope or a pencil eraser, you don't have a vein. If you find one that has a pulse, you don't have a vein. The ones that have no give may be tendons or maybe even nerve bundles. The ones that have a pulse are arteries. We are not sticking needles in arteries. That's kind of a bad thing. So when you're going to go to perform your venipuncture, this is presuming that we have selected our bag, we've checked it all out completely. We have made sure it's not expired, there's no particulates, it's not leaking, it's the right fluid, it's the right time, and done all of our 6 rights. We have spiked the bag and we have purged the line. Now, this is something that hasn't been covered on the PowerPoint here, but when we are purging the line, we are allowing fluid to run out of the bag and through the tubing in order to clear out all of the air. Now, one thing that you'll need to do if we go back and we look at some of these steps here. Actually, we'll come up to it here in the PowerPoint in just a second here. But we have to spike the line, hang it upright, and then sometimes pinch the drip chamber in order to get the fluid starting going. So we'll get to that here in a second. So when we go to perform our venipuncture, once blood is in the flash chamber, you'll lower the angle of the needle until almost flush with the skin and advance the needle and catheter. Never pull the catheter back over the needle or advance the needle through the catheter. Now, that leaves a lot to be desired. When we're talking about initially approaching the vein, before we even poke through the skin, you want to have your needle somewhere at about a 15 to 20 degree angle. The bevel of the needle should be up. So when you look at a needle and there's a angle, it looks like they sliced off one little edge of the needle. That sliced off angle there is the bevel. So you can see the hole through the middle of the needle. That's the bevel. That should be up. As you approach the vein at about a 15 to 20 degree angle, hopefully you are also you're holding the skin taut, because the skin will slide around with the tip of that needle. Holding the skin taut, you're going to make the venipuncture with your needle there and slowly advancing it. When I say slowly, I mean cautiously, but not so weakly and timidly that you're not ever going to get there. So you will make your venipuncture. Once you start to see blood come up the catheter and into the flash chamber, you need to advance the entire thing just a hair more, another millimeter or two at the most. Advance the whole thing a little more. The reason for this is the steel part of the needle is in the vein when you get flash, but the plastic catheter has not yet got inside the vein. So we advance it another millimeter or two to get that tip of the plastic catheter into the vein, and then we're going to advance the catheter off. Okay, so let's walk through this a little bit. We prepare all of our supplies. Up there in the upper left, you have a saline lock, if you would choose to do that. A lot of places are now suggesting starting a saline lock, and if you want to put fluids on, then you attach the fluids after the fact. The package underneath it, you can see it has a 15 on it. That is a drip set or administration set. We have a bag of IV fluid down at the bottom there. In the middle there, you have the white gauze squares, 4x4s, because you're going to have blood. You have an IV securing device. This is called a VenaGuard, sometimes called an Opside or a Tegaderm. We have a saline flush in the syringe and a wrapper there. The green thing's a constricting band, venous constricting band, often called the tourniquet. And you have an alcohol wipe up in the corner there, as well as a 20 gauge IV catheter. So we collect all of our supplies. We get our bag, we check it for the correct fluid, inspect the clarity, make sure it's not expired, make sure it's not leaking, everything looks good, we've got good color. We're going to then take out the IV tubing. We're going to straighten it out so we don't have a big coil or a big knot. On the end that is going to go into the back of the IV catheter is a smaller end, and we'll leave the cap on that. The end that's going to go into the IV bag, which has a big spike on it, and a drip chamber or a bubble in which you'll be able to fill up the fluid. That is the one that we're going to take the protective cap off, pull the protective cap off of the appropriate port in the bag, stick the spike in the bag, twist until we get it in there, put the bag upright, squeeze the drip chamber once or twice to allow it to fill 1/3 to 1/2 the way. And then if our tubing is not open, we will open the roller clamp up all the way, allow the fluid to fill that tubing, and ensure that all of the air bubbles we can get expelled from the tubing are expelled. So we'll pay attention to the other end of our tubing that would typically go in the back of the catheter. And you can see actually from this picture here, if you look real closely, they captured some drips of fluid coming out of there. It looks like little spatters coming out of there, but there's little drips of fluid coming out, and they're dripping out of that catheter, or I'm sorry, the tip tubing. So once our IV bag and our IV tubing is set up, if we're going to do a saline lock, we need to get the saline lock out, hook up our saline syringe to it, and just shoot a little saline and clear the air out of that, purge the air out of the little lock tubing or lock cap with our saline, and then have that sitting ready to go. Next, we will apply our venous constricting band above where we expect to do the venipuncture site. We're going to clean the site, remember starting in the middle where you expect to poke and moving outwards in a circular fashion, and that's using aseptic technique. So we don't go back across it because if we wipe back and forth, we're just moving germs around as opposed to if we were moving them outward. Again, hold our needle, stabilize the skin, hold it taut. You can see with the provider's gloved left thumb there, he's kind of holding the skin taut. It looks like the needle is touching his thumb, and it is not. You should not have anything touch the white catheter part of that needle. So holding your IV access device bevel up and no higher than a 45-degree angle. Like I said, usually about a 20-degree angle is right. Insert the tip of the needle into the vein and advance it until blood is seen in the flash chamber. And if you look up there into the provider's right hand, that he's got fingers on either side of the flash chamber there is blood in the chamber, and indicating that you've hit the vein. When the flash occurs, advance the device 1 to 2, they say milliliters, it should be millimeters further. Stop advancing the needle and push the catheter over the needle until the hub is in contact with the patient's skin. So you can see in this picture that the hub, the blue part of the hub, is up against the patient's skin where the needle entered the skin. You will hold on tightly to your needle so you don't lose it. It's still connected there. You're going to release the constricting band. So you pull the tourniquet. Now there's a trick to putting the constricting band on that we'll have to kind of show you in face-to-face skills days. You will then occlude the vein above. So his left thumb is actually where he suspects the end of that catheter is at. It looks like it's right on top of, right next to the hub. It is not. It's up towards where he thinks the end of that plastic catheter is. You're going to withdraw the needle and dispose of it in the sharps container, and then connect either the tubing or the lock, and in this case they've chosen a lock. You're going to attach that to the back of the catheter hub, and usually there's a little twist lock on the back there, so you'll twist that little twist lock onto the back of the catheter. Wipe up any extra blood that we have. Flush the tubing, holding on to the catheter still, not letting go of the catheter. So you crank that roller clamp all the way up there. We're going to look at the site very closely to see if there's any infiltration where it starts to puff up or become discolored, and then adjust the flow of the fluid to the desired rate. Now we're going to count the drips in that drip chamber until we get to the right rate. If when we open that baby up, if it's not a fairly good steady flow or good steady number of drips, we maybe don't have a good IV. We need to watch that very closely. Now, a 14-gauge IV is going to run like a fire hose, and a 24-gauge IV is going to run quite a bit slower. So that has a little bit to do with it. But you should be able to at least have a regular steady stream. After you know you have a good IV, then you can use either your tape or your commercial dressing to protect the site and secure the tubing in place. We can also take tape. There's a way to do taping. We'll show you how to do that on skills days, how to appropriately tape it down. And then if your service is the one that chooses to use a little antibiotic ointment, you would dab that on underneath that dressing before you put that dressing on. All right, so if you have an unsuccessful IV attempt or you need to discontinue your IV, there's a couple of things that that happens. So sometimes the vein moves away from the needle. So that's kind of unavoidable. Some people have more, we'll call them mobile veins than others, where you actually can almost watch the tip of the needle move the vein out of the way for you. Sometimes we go a little too far and we puncture one side of the vein and keep right on going right through the other side, and we don't have a good IV. Sometimes the catheter meets resistance because it runs into a valve. You remember way back when in your EMT class you learned that vessels, veins have valves. So these veins have valves, and the valves sometimes are just in the wrong spot. And we can kind of show you a little bit more on hands-on days a little bit about valves. And then sometimes our angle of insertion is all wrong. Many times if the angle of insertion is wrong, then the needle's going to puncture both sides of the vein. If you have to discontinue an IV, say it was no good, maybe it's all done, maybe it started to swell up and puff. If we're going to remove it, then we're going to remove the IV needle catheter combination and dispose of it safely. Remember, the needle should be gone already. So basically we just kind of move backwards. We take off any of those dressings. We're going to take a piece of gauze, cover up the needle site, and then we're going to quickly withdraw, shut off your IV tubing if you haven't. Quickly withdraw the catheter and the tubing all at once there, and then apply direct pressure. If you aren't quite ready to give up on your IV yet, it's not running well, but you think it's still a good IV, sometimes we can just do a little repositioning where we just will take the tape or the dressing off and move the catheter back a little bit so maybe it moves away from a valve, and that may allow the fluid to run nicer. If the patient's complaining of pain, it's swollen and whatnot, chances are you don't have a good IV. Most of the time after an IV's been established, there is really no pain. It may be slightly tender if you push right at the puncture site, but it shouldn't hurt. So if you have an unsuccessful attempt, you've got to make sure your roller clamp's clamped, or clamp your saline lock to prevent leakage and contamination, and then obviously remove your catheter. If you have to change an IV bag, changing the bag with a few milliliters of fluid left in the bag, or maybe they said change it to a different type of fluid. They recommend in the book here closing the roller clamp to prevent further fluid from entering the tubing, taking off the old bag, spiking the new bag, making sure the drip chamber remains a third to half full, and then readjusting your flow rate. I disagree with the way that they approach this. My recommendation is simply, well, let me clarify this. If your rate is going to remain the same after changing the bag, I recommend don't mess with the roller clamp. Just pinch the tubing, or sometimes there's a little clamp that slides directly across, and you just slide it across the tubing and it completely clamps the tubing. So clamp the tubing, take off the old bag, spike the new bag, make it sure it's upright, and then just unclamp it or unpinch the tubing, and it should flow then again at the same rate you had it set at. So it saves you some time. You'll of course want to recheck it to make sure that it's going to flow that same rate, but in most cases it's going to be very close. So occasionally we also do have some complications of IV therapy. Infection. We are probably not going to see infection in the field. It's just not something that occurs that quickly. Now if we were doing an interfacility transport, maybe, but they probably would have picked up on that in the hospital, sending them anyway. Infiltration, meaning that the vein went bad and fluid is leaking into the surrounding tissue. Air or catheter embolism. An air embolus can occur when we allow, we don't do a good job making sure that all of our connections are good. Air can get sucked in, and there can then be air floating around in the body, can get lodged in places. That's bad. Not common, but bad. Or if we didn't flush out the major large bubbles out of our tubing, we could get that air embolism. The catheter embolism is also called catheter shear, and where it said earlier in this technique, do not pull the needle or the catheter back over the needle. The reason for that was the end of the needle is as sharp as a surgical scalpel. So if you pull that plastic catheter back over a scalpel sharp needle, you run the risk of just trimming off a very fine little piece of plastic, or you can run right through the wall of it, but in most cases it's smaller rather than larger, and then that is set free within the vascular system and essentially becomes a floating blood clot waiting to happen. Bruising or hematomas, that's fairly common actually. Thrombosis, meaning that they get a clot that forms around the catheter, a phlebitis or an inflammation or infection right there at the vein. A pyrogenic reaction where they actually start to kind of have a fever and rash in the area, and then occasionally fluid overload. Sometimes we start an IV, we forget to pay close attention to giving or to adjusting our rate, and that sucker runs wild. That sucker runs wild, and it gives them way too much fluid, more fluid than that patient possibly could need. And in some patients, it's very, very bad. Congestive heart failure patients, this is very bad. So when we're talking infection, there's a lot of things that can potentially come up and cause that. You can read the bullet points in the text that talk a little bit more about those, but it gives you some tips on making sure that you keep certain parts clean. All right. So name some ways you can reduce your risk of infection while performing percutaneous procedures. You can take that one. You just read all those answers. So think about it. Heart failure patients, the elderly, and pediatric patients are at risk for fluid overload, so we have to be very careful. So calculating our infusion rate accurately is going to be very important. Monitor the rate of your IV infusion very carefully. Sometimes people will move their arm a little bit, and you have an IV that you thought was running slowly, all of a sudden takes off and becomes running very quickly. So you watch it close. Check for signs of fluid overload. So shortness of breath, their lung sounds start to become wet or moist. Those are two of the most major signs that you will see that indicate a fluid overload. So now we're going to step into pediatric intraosseous access. We're almost done with this chapter. The pediatric intraosseous access, we are accessing the bone marrow cavity. And again, there is an Appendix 3 that talks about adult intraosseous access. It's honestly just almost identical to that of the pediatric. So you will want to just look it over quickly, but we're talking really the same thing here. This device that they're showing you is called the EZ-IO device. I'll tell you what this is in reality. This is a drill. Okay, this is a bone needle drill. And those needles are drilled then into the bone marrow cavity. However, it's not nearly as ugly as it sounds. In fact, a lot of people will volunteer to have this done as a demonstration and come away with nothing more than it is a bit tender right at the site where they placed it, but other than that, it is not painful. So this device, there's 3 different size needles there. The bariatric needle, which is yellow, the standard adult is blue, pediatric is red, and then the training needles typically are pink. So if you're going to do intraosseous access, a lot of services have gone to this. The problem with this is those needles are very expensive and they don't have the greatest shelf life. They're not good forever. They expire. So there's a few ways that you can do intraosseous access. The EZ-IO, which is created by Vidacare, probably the most favored device right now in IO access. There's the bone injection gun, or the BIG, which is made by WaysMed. The bone injection gun is essentially a high-powered dart gun. It fires a needle, a very, very high-power spring fires a needle into the bone. It's pretty radical. It's pretty cool. We'll check it out when we have skills days. Yeah, so the BIG, manual access, which many places this is still what they're doing. They're using a manual needle. If you look in your textbook on page 314, you will see what's referred to as the Jamashidi needle, or the manual intraosseous needle. And basically you're going to take it, you're going to twist it, and it's going to twist right into the bone. This is not hard to do. The biggest problem with this, people will struggle with this, but by bending, they'll bend a needle when they're trying to do this. The problem is not the needle or the patient. It is that the provider tried too hard. In most cases, it's still going to go there. You just need to lighten up. You will not attempt to place an IO if you can't locate the appropriate landmarks, and you should try to not place IOs in patients with certain medical conditions like osteogenesis imperfecta, which is a bone condition. You will also try not to place it in tissues that are either burned or in bones that are broken. So we'll need to select all of our equipment again. So if we're going to go with a bag of fluid, we'll get our bag of fluid there. We've got gauze, alcohol wipes, iodine, some tape. There's some rolls of gauze there because you need to kind of put some bulky dressings around your needle in order to stabilize it. We have IV tubing. They've chosen to use the Easy IO, so we've got the needle driver and then a needle. There's a little label as well that you can use on them. They come with a wristband, which you see in yellow there, that lets people know, hey, there's an Easy IO somewhere. Some saline flushes, and they have a IV extension tubing or a saline lock there. What is missing here, probably that it's suggested, is that they use something called a stopcock, which is a gate valve. So you can actually hook several different tubings or syringes into one specific hub, and you can turn certain gates off and certain gates on, and it usually makes the process a little easier for us to administer fluid. Look for our landmarks. So we're going to find the proper insertion site. We're going to take 2 finger breadths below the tibial tuberosity along the anteromedial surface. Wow, that sounds awesome. What does that mean? That means find your kneecap. Run your fingers down until you find the ridge of your tibia right below your kneecap, directly below your patella. Move towards the middle. Okay, so once you kind of find that ridge directly, the shin that you're going to bang into everything, move your fingers just a little bit inward. Okay, there's a nice big flat spot there. That's about where you're going to go. So if you bend their knee a little bit, you'll find, okay, you're palpating your knee. There's kind of a knobby end of that knee right below the kneecap there. That flat spot below that knobby part is where you're going to go with this needle. So you can see where his fingers are placed about right. So everybody find that on yourself. Find that the ridge underneath your kneecap. Move to the middle a little bit, just slightly, ever so slightly. Find the knobby top of your tibia, and then that flat kind of surface right there below the knob. And that's where you're going to be going, 2 finger widths below that knob. So 2 finger breadths below and along the anteromedial surface. Once you've found that, you're going to assess the needle that you've chosen and make sure that it's the correct size for the patient. This is a pediatric patient. That is a pediatric needle. It's actually probably a training needle. But anyway, so it should be the right size for this patient. You don't necessarily have to pull the needle cap off of there, but so you ensure you have the correct needle. Cleanse the site. They prefer iodine. Iodine's fine. The others are fine as well. Attach your needle to the driver. Remove the cap. hold the driver at a 90-degree angle to the leg and drill the needle into the bone. This is with ever so slight of pressure. You just need a small amount of pressure on that needle, and it will basically pull itself into the bone. So it's not something you're going to have to even be forceful with. Even the person with just enough strength to lift the driver can basically put this thing in. Once the needle is into place, then you're going to unscrew the top part of it and pull out the trocar, or the solid part, out of the middle of the needle. You're going to withdraw that. You're going to hook up your tubing, and in this case they've chosen they're going to hook up the lock or extension tubing with the saline flush on it, and you're going to flush the needle. We used to say you were going to aspirate through the needle. That's not common anymore. If you want to, you can. It's not necessary though. So you can aspirate a little to see if you can get some blood to come back. Otherwise, you hook up some fluid and then try to push a little bit of fluid through there. Do not push it too fast, because they will feel some pressure. Although this shouldn't be painful, they will feel the pressure of the fluid going in. So, and then you're going to want to watch to see that there's no swelling around it. Once that we know we're in good shape, we can hook up our IV tubing and then adjust our rate flow. It may not flow quite as nicely as an IV would. In some cases, that's why we would use the gate valve or the stopcock to help us flush fluid through as needed. And then we're going to attach the tubing, and then we will put some padding around. You can see they've kind of sandwiched the needle between two rolls of gauze, and then taped it into place. They've also put that yellow bracelet or band around his ankle, so anybody else who takes care of him in the future will see that, hey, what's this? And it will draw their attention to his intraosseous. So some potential complications of I.O. and attempts and access. We can get incorrect placement. It's not common. As long as you find a nice landmark there, it's fairly easy to get it placed. Just be cautious of finding the right landmarks. Occasionally you'll also get an obstruction of the needle. In most cases though, if you are using let's say you're using the needles as supplied, there's a trocar in there that should keep it from becoming obstructed. Once in a while there may be something within the bone marrow cavity that kind of causes an issue. Fracture, it is possible to break a bone by doing this. Sometimes we just don't know they have an illness, and that could happen. Infection could happen, but again, medical asepsis is very, very key to making sure that doesn't happen. An infection within a bone is a really bad thing, so it's especially important to be clean here. A compartment syndrome can occur, and a compartment syndrome is when you get severe swelling within a muscle, and that swelling then causes, it's restricted by the tissue around the muscle, which is called fascia, and then the swelling almost works in reverse. Because it's so swollen, it can't swell outward anymore, it swells inward, and that swelling inward really starts to destroy muscle tissue. And then occasionally you can also get a fat embolus. So the fat embolus is another kind of oddball situation where you might pick something up going through the skin and whatnot. Occasionally there's also a little bit of fat in the marrow. All right, so it goes back to that think about it from early in the chapter is actually part 1. I will take just a moment before we move forward into the summary to go talk about the manual interosseous needle. That manual interosseous needle is, you're going to do this manually. You just hold it there's the collar, the adjustable plastic disc. You hold the needle firmly, 90-degree angle, and just ever so slight twisting of the wrist a little bit. not with a lot of pressure, just a very slight amount of twisting, will then get that to pop then into the bone marrow cavity. You will feel a slight give when either your EZ-IO needle gets in there or your manual intraosseous or Jamashidi needle gets in there. With the Jamashidi needle, you're going to then adjust. You can screw down the adjustable plastic disc and make it come closer to the skin. And then there's a little twist mechanism or a screw-on mechanism up on the back side away from the needle, where you'll pull that trocar out and leave the outer steel needle within the bone marrow. Works the same, it just isn't as fancy. So in summary, there's a lot of responsibility that goes along with medication administration. If we follow safety principles of the 6 rights, and you have professional obligations to your patients to make sure that this is the most appropriate time for this patient to receive this. We have to be their advocates. Ensure that the medication is indicated and not contraindicated. Obviously, give the right medication to the right patient. That's kind of like a no-brainer. Carefully calculate and verify drug doses. Select proper routes of administration. Administer them at the right time and rate. Document details of medication administration. Aseptic technique helps us minimize the risks of infection. Knowing and using the proper equipment is critical. Know how to troubleshoot problems, so know enough about your equipment and your skills that you're performing to be able to troubleshoot, and then look for signs of complication during reassessment. Okay, that wraps up the Chapter 12 lectures. Remember that if you have not read Chapter 12, you need to read the entire chapter. You should take notes. There's also going to be the short little review lecture on adult intraosseous infusion, which is Appendix 3, and some supplemental lectures on drug calculations.